So we're just going to discuss managing competent squints, and we've looked at the non-surgical management. Dr. Ankush has covered that very beautifully. So we're essentially going to focus on the surgical management. But before that, you have to make sure that, the important things before you decide the surgical management is the visual acuity of both the eyes that should be looked at, the refraction, which should be a cycloplegic refraction as was described. You need to look at the head posture. Is there a face turn? Is there a chin lift? Is there a head tilt? Any of the head postures, you need to note this down. And these should be there in your notes, before you decide the surgical management. It's important to do that. The measurement of squint and up, primary and down gazes, near and distance. Look for any horizontal incompetence. Look for any vertical incompetence like the obliques here, or any horizontal incompetence. So these are things that you need to note, and you need to look at the sensory status of the patient, because these are important things that are going to help you in deciding your surgical management as well as the outcome of the management. The non-surgical management has already been covered, so we're shifting now to surgery. And in surgical management, what is it that you're wanting to operate for, or what is the management going to be done for? So the management is done either, it's for both a functional and a cosmetic gain. We try to aim for both, and it's basically done for a primary position deviation which is there, and you're essentially correcting the horizontal when you're looking at a competent squint, and you're correcting the vertical using the cyclovertical muscles. What is the surgery done for? It's done for distance, primary gaze, that's what you're aiming for. You have to aim for the static component of the squint, not the dynamic component. The dynamic component is the one which is corrected through glasses, and or maybe some medicine sometimes, cycloplegics, but the static component is what needs to be operated for. And how do you decide surgery? So, esotropia, all infantile esotropes need to be operated, and we need to operate them once the amblyopia is corrected. All manifest exotropes need to be operated, and for intermittent exotropia, what's important is that you need to operate if they're breaking more than 50% of the times. You're losing stereopsis, you're losing, or the Newcastle score is more than 4. So there are various criteria which have been defined. So it's important to know your reason for surgery, and that's something that should also be mentioned down in your notes. The important aspects when you decide surgery is the age of the patient. It's important to know about this anatomical status. Is the eye small or large? In a very young child, you need to adjust your surgery accordingly because the eyeball will also be small. You also need to be careful that if it's an exo, you don't want him to go into an esotropia. You need to see it's an esotropia or an exotropia. You need to look at the sensory status. Is there a central fixation, eccentric fixation, any previous surgery, associated nystagmus, DVD, obliques. So all of that is something that are important aspects when you decide the surgical management. The surgical procedures for any competent squint and for any squint would be a weakening, strengthening, or a redirection of force. So these are the three basic forms of surgical procedures. When it comes down to weakening procedures, you're looking at, for the recti, it's essentially a recession, which is a graded recession, which is the most commonly used weakening procedure. And there are various variants to it. You could do a hangback, a hemi-hangback, you could have a slanting insertion, you could, and apart from that, then there are other procedures for the obliques, which will be covered later on in the talks on pattern strabismus, so whether that's a tenotomy, tenectomy, or myotomy. And the strengthening procedures is essentially a resection or an advancement, and tucking. So these are different strengthening procedures that are used, and I'm sure they'll be shown. We'll look at one video of a recession resection, a conventional recession resection later on in the presentation. And then there are procedures which redirect force. These are transposition procedures, and I think you'll see them as well later on in the talks. How much effect does each of these procedures do? That's one thing that has to be looked at. So it's different for the medial rectus, for the lateral rectus. The medial rectus surgery gets more effect. It's different for recession and resection. And this is a very, very rough estimate, somewhere between 2.5 to 3.5 prisms per millimeter for the muscle and for the particular surgery that you would be doing. And there are different alternates that you can do, whether it's a hangback or slanting insertion. That's again something which is used to correct patterns, and we'll come to that. There are minimums and maximums described for each muscle and each type of surgery. For recession, there's different. For resection, there's different. But on the whole, the minimum kind of surgery that you're doing for a medial rectus would be about 3.5 millimeters. You'll go up to 6 millimeters. For the lateral rectus, we can go more up to about 8 millimeters. And so, this is something that has to be looked at, because if you don't follow these, you'll end up generating some sort of incompetence, or the effectivity of the surgery will not be there. Normograms are available to decide surgery, so depending on the deviation, you have normograms, but pretty much this is like the maximum that you can correct quite comfortably without generating incompetence. People have gone up to 9 millimeters on the lateral rectus as well, but then the more you do in a unilateral case, you may end up with palpebral aperture changes. But there are certain advantages that a unilateral resection procedure would have, and these are that you have a higher amount of effect of the surgery, and in adults you don't have to block both the eyes. You could give a block in one of the eyes, versus the ideal surgery, of course, for any squint is a symmetrizing surgery, so would be a bilateral recession. And in children, we often do that, so you want to do a symmetrization surgery. And The important aspects that you need to look at and you need to understand here are that the medial rectus surgery has more effect. There is a 25% higher effect in infants, there's a 25% higher effect if you're doing a resect procedure, and that there are certain other factors which affect the outcome, which we've discussed, some of which we've discussed, whether it was the age of the patient, it was the sensory status of the patient, and there are some surgical factors as well which come into the being here, and these this depends on where as a surgeon you're placing your sutures, how much are you resecting, how much sag are you leaving in the muscle when you're doing a resection, and how much dissection are you doing. But then this is something, over time, one has to titrate their results and titrate the nomogram. So you could begin with a nomogram as a beginner surgeon and then go on to titrate your results because you would know how much effect you're actually getting. So let's quickly move on to this video. This is the video showing a conventional resection. This is using the fornix-based approach. You're making an incision in the fornix, which is about 8 millimeters from the limbus. You're passing a smaller Jensen's hook, then we are passing a bigger Green's hook, and now here we are hooking the muscle. And it's important here, you see, to get the right plane. So you have to be below the muscle, you have to be through the tenons. After that, you can use the lens hook to reflect the conjunctiva, then do a dissection. You need to cut the check ligaments, you need to dissect out all the tenons. The muscle sheath, some people want to leave it intact, some people dissect it out. But I think if you either way is good, but leaving it intact does help. Sometimes it prevents any a bleed from the muscles, etc. This is to be followed by putting sutures, and these are full thickness sutures, which we use a 6-0 Weichel suture to do so. It's just off the sclera on the muscle, so that there's a little bit of muscle stump when you finally cut the muscle from the sclera from its attachment. And we pass a full thickness bite from one side, we take another full thickness bite, which is locking bite, and then often I take a partial thickness bite to make sure that it doesn't slip through, and then tie a knot there, and the same procedure is repeated on the other side of the muscle. So this is going to happen on both the sides. After that, you've dissected the muscle, cut it from the stump, you measure it using the caliper. It's important to hold the existing stump in the center, because if you hold on one of the ends, then you can the insertion would change its position and you could get a wrong marking. Then we do a partial thickness bite through the sclera using the same needle from both the ends, and we tie the muscle back to its new insertion. And it's always a good idea before you take your final ties to remeasure and recheck it, and then a knot should be taken with the 6-0 Weichel suture. We cautery the stump a little bit. This helps, you always first should trim it, then cautery it, helps to bleed, and the conjunctiva is then closed with the 8-0 Weichel suture. It's always important whenever you're doing any procedure, in the beginning to look for a force reduction test, and at the end to look for a force reduction test, more so for resections than for recessions. In the resections, what you do is to hold the muscle with 2 hooks, again measure it with the caliper as we just did, and we pass sutures now from the point where we want to cut the tendon, so that the amount that's to be resected is measured here. We use 2 double-armed sutures essentially, so that there are 4 needles, and that gives you a much better strength, because in resection the muscle is going to have a certain tug or pull backwards, and you don't want it to sag, and that's why we take 2 double-armed sutures. Again, there's I generally divide the muscle into mentally into 3 quadrants, and start from the outer third for the first bite, and then another bite which is from the outer third outwards, that's locking, and then 1 bite from the outside to the in. So 2 needles are going from the borders of the muscle, and 2 are coming from within. And then we tie the muscle back to its original insertion after we've dissected out the needle, and then we close the conjunctiva after that. It's important in a resection always to ensure that the knots are tight and the muscle is not sagging behind, because then your effectivity of the resection will reduce if there's any sag in the muscle. The possible outcomes in any surgery, and this is actually described for esotropias, but the possible outcomes in any surgery could be optimal, where you're getting an orthotropic correction. There is you've got a sensory gain, and there is a binocularity, the fusional amplitudes are good, and obviously it's cosmetically acceptable because it's an orthotropia. It could also be desirable where you have maybe a mild foveal suppression of the parafoveal fixation. There are these fusional amplitudes may be less than normal, but there's a fairly straight looking squint or a microtropia could be there. Acceptable is a small angle residual which is there with probably some amblyopia or suppression which is there, and acceptable squints onwards, then your long-term outcomes start getting poorer, and unacceptable is a large angle deviation even after the surgery which may remain, and then there's definitely no binocularity here, and there's suppression. So what happens if you've got an esotropia and you've undercorrected it? One is that you go back and if it's a small undercorrection, you could just go back and treat it with glasses, have a look at it. If it's a larger undercorrection, you would often have to continue patching and think of a second surgery. If an ESO, on the other hand, is overcorrected, we're not as worried in children because an exotropia is not as bad as an esotropia when it comes down to the sensory situation. And here we could wait and watch, or again we could look at glasses, we could undercorrect them. On the exotropia, if there's an undercorrection, again we're not so worried. For a small undercorrection, you could simply follow up. Prisms, glasses can be used. For a larger undercorrection, one would have to consider surgery as well again. And overcorrection is not too good in an exo in a child. That's something we don't want to do and we want to avoid. And in such cases, again, one would often need to maybe go back, look at it optically or surgically to correct it. The follow-up typically that we use, what are the things that cause recurrence of squint? So recurrence of squint may be seen about a fair number of patients for a beginner and then 10% for somebody who's better. And here there are various factors. If you've missed any obliques, you've missed nystagmus, not given a proper optical correction, the sensory status was poor. In these cases, or the outcome was not good, recurrence is going to happen. And recurrence of amblyopia is also known. The follow-up protocol that I usually use is have a look at them the next day, then 1 week, then 1 month, 3 months, and so on and so forth, depending on, if it's a child, you want to do more frequent follow-up. So this, in a nutshell, is the surgical management of a comitant squint, along with the recession and resection video. Thank you.